dose of xylitol
10.
per day? 10. So if you take 6 3 times a day, how many are you going to get?
18.
Yeah, what's going to happen?
Overdose.
There you go.
You're going to kill all that bacteria.
Yeah, you will kill the bacteria. Then you'll have a few other problems. Okay. Okay, how does xylitol work? A.
Competes with the sucrose.
Right. Question?
I thought it was 6 grams 3 times per day because the 6 grams will be distributed throughout the day. So like 2 grams 3 times a day is what I was thinking.
Oh.
Yeah, so when you write
That's a good way to
prescriptions, the way that they're going to be written is it's going to be like if you get amoxicillin, you get 500 milligrams 2 times a day, and then you'll get a total of 1,000. So that's the way they're typically written. So, but yeah, you want to pay attention to that.
Now that we know that, would you be willing to give that question to us?
Yeah.
Let me look at it. Let's see how everybody did.
I can tell you.
All right. So yeah, A. So xylitol does 2 things. It competes with the transport mechanism and it competes with the metabolic sites as well. Okay. 3.
D.
D. Lozenges. No, not lozenges.
Oh.
Hey, you just confused us.
I just take the first answer. You guys just holler it out. I'll take the first one. C. Nasal sprays. You squirt it up your nose. It's not going to help your caries. Okay, so when you have a pregnant patient and you give the pregnant patient xylitol, what happens?
B.
Yeah, so it actually causes a long-term reaction.
Oh, dang it.
So one of the first lectures we did, remember how we talked about how the body recognizes self or recognizes biofilms within the first few years of when you're first born. So a newborn is just recognizing self. So if they start out with a really healthy biofilm, they recognize that as themselves. If they start out with an unhealthy biofilm, they recognize that as themselves. So if you make that change early on for them, you get a long-term reduction. Long-term reduction. Okay, question number 5. What did they find out?
This was the tricky one.
This does seem to be tricky for you.
Yeah.
Okay, so are xylitol products expensive?
Yes.
Well, more expensive than sugar anyway. Calculating the amount of xylitol in different products, is that always straightforward?
No.
No, because you don't know, you can look at the package, the back of the package and it says xylitol, but you don't know if you're doing this much or this much.
All right.
Telling your patients to chew xylitol gum means that they're going to chew it, right? I know. So it's D.
Oh.
Xylitol is actually sweeter than sugar.
Okay. Which sugar are you?
I think the wording
All
of
of
that
the
question
sugars.
is a little
Yeah.
tricky because it's like,
Because there's a
we
negative.
thought that they mentioned all of them maybe?
Which sugar are you talking about when you say sugar?
Sugar.
Sucrose, fructose. Because the articles show that sucrose and xylitol both have 1 gram of
1 gram of sweetness. I might just drop this one.
I mean, if they got it right, I think you should just give
Give it to
credit.
me.
Yeah.
I mean, I read it.
Find interesting trend of results.
So what I don't like is the negative. The negative in the question. I think that throws it off. Okay. Back to talk about preventative dental products. This probably won't be as disturbing to you guys as it is to the dental students. The dental students just love their handpieces, but yeah, using the handpiece, you can't, once you cut it, you can't put it back. So we try to use the handpiece as little as possible. These are the things that you're going to need to remember from this lecture. So there's three things. We're going to talk about non-invasive management of caries. So we're going to talk about diet, we're going to talk about in-office treatments, and we're going to talk about at-home treatments. So when you go through the lecture afterwards and review this, you're going to want to know all the diet things, all the in-office treatments, and all the at-home treatments. We're going to talk a lot about fluoride. Not necessarily because fluoride is the most important thing that we have, but it is the thing that is used most often. So we're going to talk a lot about it.
It was.
It was
Then it got removed.
Wait, I downloaded it yesterday, but it's
Not
kind
there
of
today.
different now.
Let's see.
From the files.
Non-files.
It's under files and I didn't put it over to the module.
No, wait, which one?
Preventive dental.
Sweet.
Yeah, so it's a preventive dental products file.
Perfect.
Now you found it?
Yes.
It's in 5.
Mine is not working. Okay, but you can find it under files. Oh, there we go. Sorry, now it's there. Maybe. Okay, so yeah, so fluoride is important because we use it a lot, and you're probably going to get some board exam questions on it. So you're going to need to know all these different things. So how much fluoride do you need for remineralization? What's the potential toxic dose? What's the acute lethal dose? What does fluoride toxicity look like? How much fluoride do you need in your water? All these things are. What is fluorosis? How do you get it? The American Academy of Pediatric Dentistry recommendations for fluoride. You want to know those also. But we'll go over all this. Okay, so there's all sorts of fluoride. There's fluorine, which is just the fluoride ion. There's amorphous calcium fluorophosphate. If you can say that rapidly 3 times, you're doing better than I am. Stannous fluoride, sodium fluoride. The form doesn't matter so much, it's just how easily is it for the body to get to it. So bioavailability is what is most important. As far as remineralization goes, you don't need a ton of fluoride to remineralize teeth. Probably 1/100th of a part per million is enough fluoride to remineralize enamel. which is a lot less than what you get in your toothpaste or that you get in your drinking water. So you don't really need a lot of fluoride to remineralize enamel. If you're using fluoride for some other purpose, like decreasing sensitivity or something like that, then then you're going to need more fluoride. But just for straight remineralization, it doesn't take a lot. Okay, so just like everything else in life, moderation is important. So a little fluoride is good. A little bit will enhance remineralization. It inhibits demineralization. It will even inhibit plaque formation a little bit. It can decrease sensitivity on roots. So a little bit is really good. Too much fluoride is just that, too much. In high doses, it can be a poison. So in fact, that's what it was first developed as. It was a rat poison. So, they just killed a lot of rats with healthy teeth. But because of the widespread use of fluoride now, systemic fluoride supplements is not recommended. So it's no longer the standard of care. Maybe if you were in an area that didn't have fluoride in the water and they didn't have any other access to fluoride, then maybe you'd think about it, but there's usually some fluoride available somewhere. So for normal patients, fluoride supplements are not recommended. And it's the standard of care for your high-risk patients. So again, you want to use your caries risk assessment. You want to know who you're treating. Giving a lot of fluoride to somebody who's low caries risk is probably not going to do a lot except annoy them because they're already at low caries risk. So you're not really helping them out that much. So know who your patients are. And the topical application of fluoride is much better than the systemic application of fluoride. So as far as how much is too much, as far as making you sick, your probable toxic dose is about 5 milligrams per kilogram. So about 5 milligrams of fluoride per kilogram of body weight is going to start giving you some symptoms for fluoride toxicity. The acute lethal dose, for adults, it's about 5 to 10 grams of sodium fluoride, or 2.5 to 5 grams of just plain old fluoride ion. And that depends on your body weight as well, but so somewhere between 5 and 10. For children, 36 milligrams per kilogram of sodium fluoride is about the acute lethal dose. So that means for 3-year-olds, about 500 milligrams of sodium fluoride would be probably lethal. For a 6-year-old, about half again as much, and for a 9-year-old, they'd have to have about a gram. Okay? So fluoride isn't. Fluoride can be harmful. So you have to make sure that it's that you use it correctly. So what happens when you get too much fluoride? So at first it's gonna help with salivation, but this is not probably the way you want to treat your xerostomach patients. You start out with excessive salivation, then you get some nausea and vomiting, some abdominal pain, and as the dosage goes up, you can have some diarrhea or convulsions, or if you get enough, you can die from fluoride. Again, this is not just something that you want to pass out to everybody. because it can cause problems. So, yeah. So for if your patient is just having a little bit of GI issues, just a stomach ache or something, then you can have them drink milk or take some calcium salts, or maybe try to get them to throw up to take care of it. But if it's more than just they feel sick, if they start vomiting or having any of the other symptoms, you need to get them into the ER quickly. All right, so you can figure out how much fluoride is in a tube of toothpaste. And I used to have everybody do this, but then I decided that I was probably testing their ability to do math more than their ability to treat patients. So I'm not going to ask you how many grams of or milligrams of fluoride is in a tube of toothpaste, but just know that you can figure it out. If we go back a couple, if you just remembering these here. If your 3-year-old eats a 500 milligram tube of toothpaste, that's probably not a good idea. So just remember these totals here as far as toxicity goes, or acute lethal dose goes. I'm not going to test you on exactly how many milligrams of fluoride there might be in a tube of toothpaste. Okay? Because it's just all math. Okay. All right, so what is fluorosis? We went over this a little bit already. Fluorosis is a hypomineralization or hypermineralization? Hypo, yeah. So it's actually the fluorosis has less mineral in it. A tooth that has fluorosis has less mineral in it than a healthy tooth. Who gets fluorosis? Adults or children? So it's only in developing teeth. Okay. Can you get fluorosis from too much topical fluoride? No, because it's in the developing teeth. It's not going to cause already erupted teeth to have fluorosis. Okay? So good. So you guys know most of this already. All right? So we're mostly concerned with fluorosis. Young children with the developing teeth, and it's from the systemic use of fluoride. So if they're taking fluoride supplements, or if they live in an area that has a lot of fluoride naturally in the water, then you can start seeing fluorosis. So the American Academy of Pediatric Dentistry recommends that you don't use fluoride for children who are less than 2 years old, because they've got a lot of developing teeth, and B, they don't always spit so good, so they're going to be swallowing a lot of that toothpaste. So for your kids less than 2 years old, they just recommend a moist toothbrush. For your kids between 2 and 6, they recommend just a little smear of toothpaste. So just a little taste of the toothpaste on the brush. And that should remember, you don't need a ton of fluoride to get remineralization. So this should be enough to help them remineralize their teeth. And then for children older than 8 or adults who can't get fluorosis, then you can put the pea-size amount or more on the toothbrush. So for your adults who have some gum recession and they have some sensitive teeth, using more fluoride will help with the sensitivity. You don't really need more toothpaste to get more remineralization. It will just help with other things like sensitivity. Okay. What do you do if your patient gets fluorosis? How do you make those ugly white spots go away? And it kind of depends on the severity of the case. So for your slight cases, sometimes a bleaching will take care of it. But as the cases get more severe, you're going to need to do like composite fillings or maybe some crowns or veneers over the teeth to take care of the fluorosis. Because it can go from anywhere like this up here to down here where there's actually chunks of the tooth missing, just because it's so little mineral content in there. So these ones you could probably bleach, and that would kind of even out those white spots a little bit. This one, the differences are a lot greater between the brown and the white. You probably need to do some sort of veneer over it, and then where you're actually missing tooth structure, you're probably going to end up putting a crown on top of the tooth or something. Okay, so when they first introduced fluoridation into the water, there was a sharp drop in the rate of dental caries in the general population. So it really worked. It does a really good job. But again, it only works if you drink the water. So back in the 1940s, 50s, when this was introduced, people were just drinking out of the tap. That's just the way we did it. Now we have filtered water, we buy bottled water, so maybe we're not getting as much of the benefit of the fluoride in the water as we were back then. Charcoal filtration, if some people put a filter system on their tap water, and the charcoal filtration will take out some of the fluoride from the water, but only until that filter is full of fluoride, and then it doesn't filter it out anymore. But it usually takes, depending on the filtration system, somewhere between 8 and 40 liters of water before that gets overwhelmed. So it seems kind of like Captain Obvious, but water fluoridation only works if you drink the water. So if you're drinking bottled water, or if you have a filtration system, or if you just don't drink tap water, if you like my daughter and think tap water is just gross, then yeah, maybe it doesn't work so much. So the optimal concentrations for water was developed back in the 50s and 60s, and they decided that you need to have about 2 to 5 milligrams of fluoride daily, and so they decided that people are drinking normally between 2 and 5 liters a day. And so then they worked backwards to figure out how much fluoride needs to be in the water. So they decided that 0.7 parts per million would be good in a hot climate, because they're assuming that people are going to be drinking more in a hot climate than in a cold climate. They're thinking people drink less water, so they would need to put more fluoride in places like Anchorage or something like that. And the way they decided, they looked at how much fluoride in the water would before they would see the first signs of fluorosis, and so then they worked down from there. So they established the optimal amount of fluoride as the amount just before you would see fluorosis, the initial signs of fluorosis. So the levels may be a little bit high. Because again, remember, how much fluoride do you need for remineralization? You don't need 7/10, you need like 1/100. So you probably don't need this much fluoride in your water to get to maintain healthy teeth. So it may be a little bit high. So that's why I'm not too worried about people drinking other water or putting filters on their water, because I think they're still probably going to get enough. Okay. But just remember these values. because that will probably come up again at some point. Okay, so lots of times when you take out a tooth, you see a brown spot on the mesial or distal of the neighboring tooth, and it's nice and smooth, and the tooth is intact, and it's just a remineralized carious lesion. So we said that remineralized carious lesions often look like white spot lesions. So why do these lesions, or why do these remineralized lesions look brown? And it's just some extrinsic stains that get incorporated into the lesion during the remineralization process. So it doesn't mean that this is unhealthy. It just means that it got stained from coffee or Coke or whatever was in the patient's diet when that tooth was getting remineralized. So again, color doesn't tell you a lot about a carious lesion. It's more the surface texture that will tell you something. So if it's nice and smooth when you drag an Explorer across there, that's a nice remineralized lesion, and you don't have to do anything else about it. If it's a little bit rough, then it's not remineralized, and so you have to remineralize it at that time. Okay. So when you're talking about non-invasive management of carious lesions, there's a few things that you need to remember. So luckily for us, caries is a slowly progressing disease. It's been estimated that under normal conditions, initial caries lesions takes between about 3 to 4 years to cavitate, or to become the hole in the tooth that the patient can recognize. So if you're looking at a carious lesion or an initial lesion, and you're wondering, what should I do about this? Should I recommend that my doctor drill this out and put a filling in there, or should we try to remineralize it? Go with the least invasive choice that you have, because in 6 months, even if worst case scenario, patient doesn't do what you ask them, they don't chew their xylitol gum, they don't incorporate more arginine in their diet, they refuse to brush with fluoridated toothpaste, and the lesion grows. In 6 months, when you have them back for a regular checkup, it's only going to have grown a little bit, and you can still do a filling at that time. So you haven't lost anything, or you haven't put the patient at increased risk. So whenever I have to choose, I usually go with the least invasive treatment possible. There are exceptions to everything, and to this rule there's an exception as well. So for your extreme risk patients, your patients who have very little salivary flow or no salivary flow, your patients who have drug abuse problems, or your little patients with early childhood caries, these different types of caries progresses really quickly, and in these cases you should probably be more aggressive rather than less aggressive. So for those exceptions, then you'll probably be leaning more to the surgical side than the non-surgical side, while you try to figure out what's putting them at such high risk and lowering that as well. Okay, but normally we have plenty of time to treat these non-invasively. So we're going to go over 3 different kinds of treatments this morning. First, so diet modification and in-office treatments are our diet modification and at-home treatments are kind of the same, but we're going to separate them. So we're going to talk about diet modification. We're going to talk about some things that we can do in the office And then we're going to talk about some things that the patient can do at home as well. So first off, you guys spent a lot of time reading about the alcohol sugars. So most common is xylitol, but erythritol is becoming more common as well. And we'll talk about the foods that are rich in arginine. Okay, so we talked about arginine a little bit already, yes.
I know we talked about make sure that have increase in fluoride for those who have history of drug abuse, but how about for like babies, or like children that have parents that see cocaine? Does that really apply?
Not so much.
Okay.
Yeah. So the risk comes from they're probably still at increased risk because their parents are taking care of them as much. Okay, so arginine. So we talked a little bit about arginine already when we talked about saliva. But when the arginine is metabolized, it creates ammonia, which is very basic, which raises the pH in the mouth, and it makes it harder for the carcinogenic bacteria to survive. And we have a number of studies that support this. So there was one 2-year study that compared children that they added an arginine calcium salt to the fluoridated toothpaste. And when they compared these children to the children that didn't have the arginine toothpaste, there was a difference of almost 20% in their DMFT scores. And that was to children who were still using fluoridated toothpaste. So that's in addition to the effect of the fluoride. So it's helpful. Unfortunately, we don't have FDA approval to put fluoride in the toothpaste, or to put arginine in the toothpaste in the United States. So we have to get our arginine somewhere else. But there's arginine in lots of the different foods that we eat. So nuts, cheeses, hard cheeses typically have more arginine than soft cheeses, but even the string cheese has some arginine in it. Spinach, dark green leafy vegetables, lentils, they all have some fluoride or some arginine in them. Turkey is a good source of fluoride. Chicken also, but you can even be vegan and have some arginine. But yeah, so we've got good evidence that shows that arginine decreases the caries rate. You can get, yes?
Why would arginine not be FDA approved in toothpaste?
So FDA approval is, it's expensive. So to get the FDA approval is expensive. And then whoever spends all the money, then to get the approval, then their competitors can use the arginine, and so there's a little bit of I'm not going to spend the money because then you guys are going to take advantage of it. So there's a little bit of that going on. It's also a little bit political with the FDA, so it's
Because it can come from animals?
I'm not sure why. The last time I talked to somebody who had worked at the FDA, they said that it was, you had to make it worth their while. But mostly it's just the expense and all the hoops that you got to jump through to get it approved, and then having all your competitors just tag along behind for no expense at all. But you can get arginine in other things. I think we talked about the basic bikes before. But these are little chews that you can give to your patient. And it has arginine bicarbonate in it as well as calcium carbonate in it. And so these little chews do two things. They raise the pH in the mouth initially just because of the calcium carbonate. So it's like rinsing with baking soda. And then the arginine tends to have more of a long-term effect because it changes the oral flora, changes the environment so that the commensal bacteria can thrive and the karyogenic bacteria don't do as well. And these, so I've tasted these before, and they taste chocolatey. I don't know if I was overthinking it a little bit. I thought they had a little bit of a soapy taste to them, but other people have said that they thought they were just fine. So your patients may look at you a little bit funny when you tell them, good checkup here, have some chocolate, but yeah, just explain it to them. So what is the metabolic pathway that changes arginine to urea? The arginine deaminase system. So you guys will want to remember the arginine deaminase system, but it takes the arginine and changes it into urea. Okay? So basic bites. All right, xylotols. Xylitol is a sugar alcohol. You get it from hardwood. You can get it from corn cobs. It has lots of antibacterial properties. The one that we're talking about right here is how it affects the karyogenic bacteria, but it also has some antibacterial plaque properties that make the plaque decrease. So it breaks down the extracellular polysaccharides and that biofilm matrix that gives the plaque that 3D structure so where it can make the little microenvironments that can be super acidic or whatever. So it not only does it interfere directly with the bacterial metabolism, but it also makes it harder for the plaque to get organized. It promotes the selection of less virulent forms of strep mutans. So there are some varieties of strep mutans that can use the xylitol, but those varieties of the mutant streptococci are less virulent, so they don't make decay like the regular strains do. And then xylitol does have a stimulating effect on saliva, so it will increase salivation a little bit as well. So it works in a number of different ways. You can get xylitol everywhere, almost everywhere. You can even get xylitol nasal sprays, which means, unless you squirt them on your teeth, is probably not going to be very helpful. But there's xylitol toothpastes, there's xylitol chewing gums, there's xylitol lozenges. I think I told you already, took my daughter to her pediatric physician, and she got her vaccination, and they gave her a lollipop, and I'm like, wait, what is that? But they had xylitol in it, so I let her have it. So it was good. But yeah, you can get xylitol in lots of different places. How much you're getting is another question. So if you're using icebreakers, not all icebreakers have xylitol in them. So you have to turn the box over and read the back of it to see if it has xylitol in it. Because some of them have xylitol, some of them have some other sugar substitutes in them. So you can't even go just on the brands. But even when it says xylitol on there, you don't know how much xylitol they put in it either. So, if you really want to know exactly how much xylitol you're getting, then you can use some of the dental manufacturers will make. I don't have any of them up there. But the dental manufacturers who make like a xylitol gum, like Carry-Free makes one, there's a bunch of different ones and they'll make them. They know how much is in there and they'll tell you, yeah, there's 1 gram of xylitol in one stick of gum. So then you can measure it out. Vitamins have, some of them will have the xylitol in it. So knowing how much xylitol you're getting is important. There was a study that was done on xylitol to determine how effective it was, but in the study they didn't use the minimum therapeutic dose when they gave the patients the xylitol. And so when they got to the end of the study, they said, well, xylitol doesn't work. But they didn't give them enough to actually make it work. So it was kind of a funny study that way. But you need to have, so this is a little bit low. So probably 6 to 10 grams of xylitol a day, divided up into multiple doses. So, yeah. So if you get 1.5 grams, what would that be? 1.5, 4 times a day, that makes 6. That would be enough. Some of the disadvantages, other than not always do you know how much xylitol your patients are eating. So my daughter tells me that the xylitol gum loses its sweetness quickly. So so your patients may tell you, I don't like the gum because it doesn't stay sweet as long as some of the other ones do. So there's a patient compliance thing that's, if they don't use it, it's not going to work. Some of the other disadvantages, if you get too much, it will cause some diarrhea. And so that's very unpleasant also. But it's you don't need a prescription for it. You can just get it over the counter. But it's best in high caries risk patients. So in the article you guys read, they took a bunch of low caries risk kids and gave them xylitol, and then they didn't notice a lot of difference because if your caries risk is low already, it's hard to make it lower, right? So it works best in high caries risk patients. Okay. So erythritol is another polyol or sugar alcohol. Some studies show that it has a little better efficacy than the xylitol does. It's not as commonly available. It's becoming mostly because it costs more. But as I'm assuming that as they ramp up production and it becomes more available, costs will come down. So you'll maybe see erythritol substituted for xylitol in some of these things. Okay, so that's kind of, when you're talking about diet, talked about the arginine, we talked about the xylitol. What did we not talk about as far as diet goes? Yeah. So there's what you eat and how often you eat it. So fewer meals spaced farther apart is probably going to help as well. Okay. And then fewer easily fermentable carbohydrates like the fishy crackers or breads or any of those kind of things. All right, so when we talk about in-office treatments, we're going to talk about fluoride again. Topical application of fluoride, we're going to talk about varnishes, which again, there's fluoride varnishes, which is another topical application, but there's other varnishes as well. We'll talk about sealants. We'll talk about resin infiltration. As you go down this list here, probably I would put a line somewhere around in here. Some of these other therapies are more experimental. Some of them have been shown to be somewhat effective, some have a lot of promise, some of them maybe not so much. But we'll talk about all of these over the next little bit here.
That's you.
Okay, topical fluoride. You all know what topical fluoride is. You've used it already. But again, you should know who you're giving it to. So giving it to a low caries risk individual probably isn't going to help that much and is just going to waste their money. You definitely don't want to overexpose your patients to fluoride. So if you have a really young patient who has problems spitting or not swallowing, so if you're worried about them getting any systemically, you want to be more careful with them. Maybe not give it to very young patients.
Bless you.
But the gel or the foam has to stay on there for about 4 minutes. And you should do it every 2 to 3 months for your high caries active patients. So anybody who has a moderate to high caries risk, older patients who are at risk for root caries, patients who have hyposalivation, those are all indications. Erupting teeth, when we talked about the chemistry of caries at the beginning of the quarter, we talked about how erupting teeth are at a higher risk for caries because they haven't gone through that remineralization, demineralization process. So putting topical fluoride on erupting teeth just helps them, helps that enamel change from that kind of pure enamel to the enamel that has the impurities like the fluoride and other things in it, and that is more resistant to decay, more resistant to demineralization. Silver diamine fluoride. How many of you guys have heard of silver diamine fluoride? Okay, a few of you. So silver diamine fluoride is another topical fluoride, but this is placed just on carious lesions. It's not placed all over the teeth like your regular fluoride is. So it has a couple of ways that it works. The silver salts are actually bactericidal. So the silver salts will kill the bacteria and inhibit the biofilm formation. And then the fluoride will help to stimulate remineralization as well as dentin formation. There's some serious disadvantages to it. While it does remineralize the carious lesion, it also turns the carious lesion black. So all of your caries is now stained black. In fact, it stains just about everything it touches. So you get it on your nice white lab jacket, it'll stain it. If you get it on your hands or on your patient's mucosa, it'll stain it. Get it on the brand new chair that your dentist just put in, it'll stain it. So you have to be really careful because it stains everything. And permanently. If you get it on your skin or the mucosa, because the skin will turn over and you grow new skin, it's not permanent, but it'll be there for a couple of weeks. Same with the mucosa. Okay, it says research is limited. That was talking about US-based research. But there's a lot of research from Japan and Australia and some other places that show that it's very effective. And now we're We're even getting some US-based research that's showing it as being effective. It was just recently approved by the FDA, so recently, 2000 and, let's see, was it the end of 2014? So I guess it's been a while now. But they got FDA approval, and the way they got FDA approval for this was they when they presented it, they said it was another topical fluoride. So they grandfathered it in with all the other topical fluorides. They didn't ask for FDA approval of the silver diamond fluoride as an anti-caries.
Why would they use it if they are stating as
Okay. So the question is, why would you use something that would make your teeth an ugly black color? So let's so we'll get to that in just a second. But it's very effective at remineralizing caries. And it's actually less expensive than other topical fluoride treatments that we have. So it's really good for people for those exceptions that I was talking about, where the decay progresses really quickly. This works really good in these cases. So your early childhood caries, your rampant decay associated with drug abuse, or for your xerostomia patients, this works really well. But yeah, it's pretty ugly looking when you put it on there. So it kills the bacteria, remineralizes the teeth. So these black areas are hard. You put your Explorer on there, and they're nice and hard. So this looks really horrible, but there's no active decay in this mouth right here. So the disadvantage is, the biggest disadvantage is that it stains the caries black and is really ugly looking. But for your, have you got, who's in here has seen a case of meth mouth already? Meth mouth? Do you guys know what meth mouth is? Yeah, it's so these patients, basically they look like this, except that instead of being black, it's the nasty brownish, whitish, gooey stuff. And a lot of these patients, they walk around like this because they don't want anybody to see their teeth. So when you, I'll get you, when they when you do this for them, and it's all in your treatment presentation. So this is an interim step. It's to get the caries under control, give you time to put some more long-term restorations in there to make it pretty again. So this is not the end treatment right here. This is just the interim step. So when you tell them that it's an interim step to get them to where they want to be, it's a little more palatable, something that they can do. Yeah, that's probably a good place to stop. You had a question?
So I have two questions. So once you put this on the patient, the only way to pretty much get rid of it is to put crowns or restorations on top of it? There's no way of getting rid of it after that?
So the question was, is there a way to get rid of the black staining once we've put it on there? And so they did propose using a potassium iodine solution to reduce the amount of staining, and it did somewhat, made it from a really dark black stain to a less black stain. So it wasn't as helpful as they would like it to be. So yeah, you're right. About the only way to get rid of that color is to, well, you could You could drill it all away, but that's kind of counterproductive. That's why we're putting it on there. We don't want to drill it all away. So the only way to do it is to cover it up with some sort of restoration. But these are cavitated already. These are holes in the teeth, so they need a restoration. So it's not that bad. But you have to be careful with what kind of restoration you put on them, because if you put a pretty translucent composite filling over the top of it, that black stain will just shine right through. So you have to mask it out with some sort of opaque layer first, and then put the composite on top of it. Or in some of these cases that are super extensive, there's just not a lot of tooth structure left, and putting a crown over the top of it is super important. But before you get to that state or that step, you have to make sure you took care of what was making their caries risk so high. Otherwise, it'll just come back again. There is an interesting phenomenon. I hate that word. Where when you use silver diamine fluoride, the little silver particles get incorporated into the remineralized tooth, and if the tooth does get a little bit of demineralization again, it will release those silver diamine particles and attack the bacteria and remineralize the tooth again. So they call it the zombie effect, because it has that little residual effect in it.
And then also, are they, for children, I know this is big in pediatric dentistry, can they just do it in one tooth and it won't travel to the other teeth?
Right. So this doesn't, it stains everything except healthy enamel. So if you have healthy enamel, it won't stain it. So for pediatric patients, So, and it doesn't take a lot. It's not like you're slathering fluoride varnish on there. You're using a little dot, one drop on a micro brush, and you're just painting it just on that carious lesion. So it's very specific. So for pediatric patients, especially if it's all in their back teeth, you can arrest it and just leave it until those teeth finish developing underneath and the baby teeth exfoliate. So it's very helpful in specific situations. You don't use it for everybody. There's some dentists who have tried to use it on crown preps. So they prep a crown, and then they put the silver diamine fluoride on it, and then they cement the crown on top of it. But it only works if there's decay there. So if you've taken away all the decay and you put it on there, it doesn't really work that well. So it's not a cure-all. It's a treatment for very specific cases, but in those very specific cases, it works well. Back to the restorations. There's been research done to compare bond strengths between like composite or glass ionomer to the silver diamine treated tooth, and then compares that to the bond strengths to healthy teeth, and they're virtually identical. So you don't have to take away all that treated tooth before you put your restoration on there. You're going to get the similar bond strengths, no matter if it's stained or not. Okay, so there's I'm not going to make you guys read all of that, but there's good evidence out there that 38% silver diamine fluoride done twice yearly is effective at remineralizing teeth and preventing decay. But probably the most important part is figuring out what's causing the patient to get so much decay, and then changing whatever risk factor or behavior factor that is so that they aren't at such high risk anymore. All right, fluoride varnish. This is something you guys know and love, I'm sure. So it's the same indications as topical fluoride. It's probably going to work a little bit better as far as sensitivity, root sensitivity goes. It's not any more effective than rinses or gels as far as remineralizing teeth. Most of the studies that we have were done on older varnishes that had about half as much fluoride in them, so the newer varnishes have 5% fluoride. One thing to remember is that the fluoride is inactivated by the chlorhexidine. So if you have your patient on chlorhexidine rinses and you give them fluoride, you've just stolen a bunch of their money. So the fluoride, if you're doing chlorhexidine, you have to you don't want to do that right on top of your fluoride varnish. There's a chlorhexidine thymol varnish as well, and they did a systematic review back in 2006, and they were able to show that had a inhibiting effect against caries, so the chlorhexidine thymol varnish, but probably not any better than just regular fluoride varnish is. Okay, resin sealants is another in-office treatment. Your resin sealants work best on pits and fissures. They don't work they don't work at all on smooth surfaces. It's hard to get the resin sealant to stick to the smooth surface. But it works best in the deep pits and fissures, helps to keep the plaque from accumulating in there. But they've done a number of studies on sealants. They're very effective at reducing the caries rate, even when the sealant has partially come out. So having half a sealant is better than no sealant at all. They were able to show that sealing a cavitated lesion significantly reduces the bacterial levels within that cavitated lesion. But these are most indicated for your high-risk patients, especially patients who are just getting their teeth freshly erupted in the mouth. So your 6-year-olds in their first molars, your 12-year-olds in their second molars, bicuspids, those kind of things. Glass ionomer sealants. So when they first developed glass ionomer sealants, the thought was that the glass ionomer acts as a fluoride reservoir, so it should be more effective at protecting the tooth than a regular resin sealant is. Systematic reviews have shown that they're both about as effective as the other. But one advantage of the glass ionomer sealants is that they're not as moisture sensitive. So if you have a little squirming 6-year-old and you're really up against it as far as controlling the field, or if you have a partially erupted tooth and there's gingival crevicular fluid seeping in on the backside of that 6-year molar, then maybe the glass ionomer sealant is going to be a little bit easier to place than a resin sealant would be. So if moisture control is an issue, then maybe the glass ionomer sealant would be more indicated. Okay, Icon is a type of resin infiltration lesion, or it's a resin infiltration restoration. So this kind of blurs the line between restorations and preventative products, because the resin infiltration or the Icon restoration it fills a non-cavitated lesion with a resin. So it's kind of a filling, but you don't have to drill a hole into the tooth. So the procedure is you etch the lesion really aggressively, and you force the resin into that etched lesion, and then you cure it, and it works. Dr. Sama Umar down in the pediatric clinic, she's been using it for it's probably about 5 years now, and so she's been having some good results with it. Some of the disadvantages is that if you take an X-ray of this treated lesion, it still shows up just like a cavity does. It looks exactly the same because the resin is an unfilled resin. It's not radio-opaque, so you can't tell that they've done a filling in there. So if your patient leaves your office and goes to Missouri or wherever to a new office, the dentist is going to be like, oh my goodness, there's all these cavities in here, and why hasn't anybody done anything about them? So that's a bit of an issue. And then once you've filled that non-cavitated lesion with resin, you can't remineralize it anymore. So remineralizing is not possible. But it's knowing the strengths and weaknesses of it, it's probably nice to have in your arsenal as far as these small lesions. All right, now we're going to get into some of the less sure things.
For the resin, does the patient have to continue to get that throughout their life, or it's just a one-time thing?
One-time thing,
Okay.
unless they get more decay, but yeah, good question. Okay, so lasers are cool, so I think that's why we keep looking at them. But the laser ablation is the use of the laser to kind of melt the deep fissures of the enamel together. So it kind of takes those little pits and fissures and kind of melts them together a little bit. So there's been some evidence, some research that shows that it works, but still pretty experimental. And since I made this slide, I haven't seen anything that shows that they're getting better results with it. So it's still kind of maybe someday in the future, but not today. Okay, ozone therapy. So ozone is used as an antimicrobial agent. So they bathe the teeth in ozone, kill all the bacteria, and supposedly take away the caries that way. But again, they haven't had any good research that shows that it's effective. And anything where they have one treatment, they said there's all these different things. So ozone therapy has been promoted as being able to take care of all these things, and it just seems a little bit too good to be true. And so far we don't have any good evidence that it really does work. So the evidence we have is kind of inconclusive, and so until we get something better, there's definitely some better choices out there. All right, photodynamic therapy. So they have so photodynamic therapy is they're trying to get an antimicrobial agent down into that deep organized plaque, and then so they're trying to sneak in this antimicrobial agent and then activate it once it gets down into the plaque. Because remember, that mature plaque has it tends to exclude antibiotics or things that are less or more basic, so it kind of protects itself. So this is a way to try to get into that really deep mature plaque. So they take an antimicrobial agent and so normally in a mouth rinse, have the patient rinse with it, and it's in it's in a form that can get down into these deep, inaccessible areas of the plaque, so it's more acidic, so it can get in there. Then they hit it with a light, and they've used different wavelengths of light, lasers, LEDs, halogen, different ones. Once it hits the light, it changes form and becomes an active antimicrobial agent, and it kills all the bugs. But probably not ready for clinical use yet. There's just recently I was at a conference where they had a different take on this, and it was a pH activated antimicrobial agent. So the acidic form of the agent, you'd rinse with that, it'd go down into the plaque, and then they would rinse with a basic agent, change the pH and activate the antimicrobial agent, and then kill the bacteria that way. So if you guys remember back to the biofilm lecture, this would be most effective if there was one bacteria that we had to worry about. But since there's a bunch of bacteria that can cause caries or that can change the environment to a caries producing environment, having one antimicrobial agent, one targeted antimicrobial agent, may be helpful in very specific cases, but not really for general clinical use. So this shows some promise, but they still need to develop it some more yet. Another thing that's showing more promise, in fact it's being used in Europe right now, is it's called guided remineralization. So what this is it's a self-assembling peptide. So it's a little protein that acts like little Lego blocks and sticks itself together. The self-assembling peptide will diffuse into the subsurface lesion, and then once it diffuses in there, it builds itself up, makes a matrix for the calcium and phosphate ions to attach to, and then the tooth gets remineralized like that. So the advantage of it is, so when we talked about remineralization before, we talked about how the lesion remineralizes from the outside in. And so there's always that little bit of demineralized tooth down below. With the self-assembling peptide, because it soaks into that lesion, it provides the matrix all the way down. So you get a more complete remineralization of the initial lesion, or that non-cavitated lesion. So they're having some good results with it in Europe, but I'm starting to sound like a broken record because we're still working on FDA approval here. But keep your eyes or ears open, because this is looking very promising. There's another guided remineralization that out there that they call it EAR, so electrically accelerated and enhanced remineralization. This one, basically it set up a gradient across both sides of the demineralized part of the tooth, and then they use iontophoresis to drive calcium and phosphate ions through the tooth, and then it remineralizes the lesion that way. I haven't seen any clinical trials yet. I've only seen where they've worked on little demineralized enamel slabs in the laboratory, so it's not even close to being on the market yet. But it's an interesting, one of the interesting things about this is the instead of doing the normal research routine, the guy who developed this, he did a lot of it on YouTube and was showing how it works on social media. So it was kind of a big thing for a while on the social media. But so he went around, he did it a little different way. So those are all things that you can do in the office. So now we're going to talk about some of the at-home treatments. So fluoride again, but we'll talk about some other things as well. Okay, so it's plaque reduction. So notice I didn't say plaque elimination, because you can have a healthy plaque. And so having that healthy plaque on your teeth is, good for you. And that plaque starts growing just about as soon as you take the toothbrush out of your mouth. So eliminating the plaque is probably unrealistic. But you're just trying to keep the plaque down below that very organized level where it has the little exclusion zones that are super acidic and those kind of things. So you're just trying to keep it down to that healthy level. So you guys probably know more about proper brushing technique than I do. But using proper technique, so lots of times your patients will come in and tell you, I brush my teeth 4 times a day and I'm still getting decayed. So you got to make sure you do it properly. You can't just brush your teeth and you have to do it properly. And you have to do it for enough time. So 2 minutes is probably enough time to brush your teeth effectively. It's an eternity if you're this old. I'll be honest, it's an eternity if you're my age. So so spending the full 2 minutes, probably not very many people will do that. And then flossing. Flossing is important. You guys probably heard somebody tell you about the study that said flossing was not effective in preventing gum disease. No? Maybe. So, but again, when people are telling you about studies, you have to read these studies carefully. So what that study actually said is that it's hard to teach patients to floss effectively. And so they said that patients can't learn how to floss effectively, and so then it's not effective. So they said that to really get to floss your teeth effectively, you have to have your hygienist do it for you. Maybe. But yeah, there's doing it the right way or doing it the wrong way is not effective at all. And fluoride toothpastes. I think this was the thing that. So I lived overseas for 16 years, and people sometimes ask me, so how, was it a very big adjustment when you came back to the United States? This was the biggest adjustment for me. Going into the store and having to choose between hundreds of different products was just overwhelming. In fact, the first time I just turned around and left because I only wanted one toothpaste. And there's just all these different toothpastes out here. But all these toothpastes are probably effective. They all have enough fluoride in them to prevent decay. And then after that, you're just looking at taste or packaging or whatever. If your patient is xerostomach, if they have problems with salivary flow, then your toothpaste selection probably gets narrowed down a little bit, because you don't want to use toothpaste that has the foaming agent, the sodium lauryl sulfate in it. So because that dries out the mouth even more. So but other than that, yeah, an ADA approved toothpaste is probably one is as good as the other. But yeah, we have some good systemic reviews that show that correctly brushing your teeth reduces the amount of decay. So, one thing that patients can do that most patients don't do is once they finish brushing their teeth, they spit out their toothpaste and then they rinse out their mouth and they rinse all the fluoride off of their teeth. So if your patient is not really excited about using the whatever you've recommended to them, like the arginine or changing their sugar out for xylitol or whatever, just getting your patient to stop rinsing the fluoride off their teeth after they brush, so spit but don't rinse, is probably an easy first step in reducing their caries risk a little bit. Easy first step. And you should have heard my daughter when I told her that she couldn't rinse out the toothpaste from her mouth. She wasn't terribly excited. All right, CPP-ACP, so calcium phosphopeptide amorphous calcium phosphates. It's a lot easier just to say MI paste. So from now on, we're going to say MI paste. But the MI paste does a couple of different things. It inhibits demineralization, helps remineralize the teeth, and it also raises the buffering capacity for the patient. So again, it's not for everybody, but if you have patients that have incipient lesions, so early carious lesions, or if you have patients with low buffering capacity, then this is helpful for them. Definitely, you want to remember that this is calcium phosphate wrapped up in a milk protein. So if your patients have a milk protein allergy, this can be a very serious threat to their health. There's been cases reported where patients died from getting MI paste. So you definitely want to, this is not just a toothpaste, this is a prescription material. So lactose intolerance, this doesn't bother patients that are lactose intolerant, only milk protein allergies. The MI paste, the remineralization effect of the MI, or the casein phosphopeptide amorphous calcium phosphate is enhanced in the presence of fluoride. So there's some forms that have fluoride added to them, and those would be called the MI paste plus, and they have the fluoride added to them. Okay. So very helpful, but you just have to use it in the cases where it's indicated. Again, not a cure-all that you can just kind of have everybody bathe in. You have to choose your cases correctly. A little more simple at-home therapy would be the baking soda. So just sodium bicarbonate. In the past, people have used it as a toothpaste. We thought my grandma was crazy because she brushed her teeth with baking soda and salt. Turns out maybe she wasn't as crazy as we thought she was. But yeah, it raises the pH. It has a little bit of abrasiveness to help clean the teeth, so it can be very helpful. The effect, just from a personal use of it, but it'll only raise the pH for a certain amount of time. So just like when you eat, your pH drops and then it slowly comes back up to your baseline level. When you brush or rinse with the baking soda, it'll raise your pH initially, but then it'll come back down to the baseline level. So it doesn't do anything to change the pH of the environment long term. It's a short term solution. In the few cases that I've looked at, that effect is about 2 hours. So after 2 hours, you're coming back down to that baseline level, wherever that was. So it's kind of good to kind of shock the system and get an initial change, but if you want a long-term change, you're going to have to do something to change the biofilm. And then you'll get a more long-term change in the pH of the mouth. So this is kind of another Captain Obvious moment. This works best with patients who have low pH. Okay, so you're going to hear some about bioactive materials. It's becoming a little bit of a buzzword, but specifically the phosphosilicate bioactive glass is another remineralization agent. And yet another agent that is not yet FDA approved. So if you happen to be vacationing in Canada and you see the Novamin, you can try it out and see how it works for you, but be careful bringing it across the border, they might arrest you. So, but yeah, so there's some evidence that shows that with a bioactive glass you can remineralize these lesions similar to what we do with the MI paste or the nanohydroxyapatite. So nanohydroxyapatite is just little nanoparticles of hydroxyapatite that they use to remineralize the teeth. And it's in the studies that I've seen, it has about the same effect as the MI paste. The depth of remineralization for the nanohydroxyapatite was a little bit more than for the MI paste, but there wasn't a statistical difference between them. So there's been some studies that have looked at adding nanohydroxyapatite to energy drinks, because energy drinks tend to be very cariogenic, and so they're looking at adding the nanohydroxyapatite to those drinks to help with remineralization. The one study that I saw, they added the nanohydroxyapatite to cola, and then they dipped little enamel strips in there to see how much they would have to add before the enamel strips would stop demineralizing. And so they were able to add enough to get the enamel to stop demineralizing, but they didn't say what it did to the taste. One of the things, the sparkly taste of soda is what people like, and so I don't know what the nanohydroxyapatite did to that. But anyway, they're using it in a bunch of different ways, but oftentimes it comes in a paste that your patients can use to brush on their teeth. That's a lot. But here's where they added the nanohydroxyapatite to the beverages, and it showed some promising results. Whether or not people would like to drink them or not is another question. All right, so the products that we use on the clinic, there's so many different products out there that it's impossible for the school to have all of them. It's just cost prohibitive. And so the school has chosen to use the carry-free products, mostly because of convenience. They all come pre-packaged and they're easy to use, but they do the same thing as a bunch of the other products do. So the different carry-free products will have a pH neutralization factor, they'll have an antibacterial factor, they have fluoride and xylitol, and then the nanohydroxyapatite as well. So the different products will have different amounts of these things in them. So there's the gel that has the nanohydroxyapatite in it. It also has some fluoride and some xylitol and some sodium bicarbonate to help to reduce the pH. So for your patients who have white spot lesions or a little bit acidic, this would probably be a good toothpaste for them to use. So like I told you, if you just give a patient a mouth rinse to raise their pH, it only lasts for a short amount of time. So there's this little throwback to the 1980s, the little mouth spray that has a pH neutralizer in it and some xylitol, so they can spray that in their mouth every couple of hours to try to boost their pH. Then there's the CTX treatment rinse. So it has some xylitol, some fluoride in it. But the most important thing that this has in it is the antibacterial component, so the sodium hypochlorite, also known as bleach, but it is a very dilute amount of sodium hypochlorite. And this has been shown to be effective at reducing bacterial levels. The nice thing about it is, with the xylitol in there, that it also does something to change the biofilm. Because just using the antimicrobial will kill everything, but you've got to do something to change the biofilm to a healthy biofilm. Otherwise, the same bacteria are going to grow back. So this is kind of nice in that it kind of combines it all together. Carry-Free also has a fluoride varnish that has some xylitol in it. Does the same thing as most fluoride varnishes do. They have a gum, so it has a nice neutral pH, and it has 1 gram of xylitol per stick of gum. So you actually know how much xylitol you're getting. And then Carry-Free also has a little flow chart that you can decide what therapy to use for what type of caries risk your patient has. So that makes it a little bit easier. Okay, so some of the rinses that we have that your patients can use at home. So there's the sodium fluoride rinses. These usually have less fluoride than toothpaste. And they're most helpful for patients that have difficulty brushing. So if your patient has arthritis or difficulty manipulating the brush, and then maybe the sodium fluoride will be helpful. But definitely does not replace toothbrushing. Toothbrushing is definitely more effective. Okay. As an antimicrobial agent, chlorhexidine is very effective, but all it does is kill the bugs. So you're going to have to do something else at the same time to change the biofilms or change the environment so that a healthy biofilm will grow back. So from an anti-caries standpoint, one way to use the chlorhexidine would be to have the patient rinse for a week with the chlorhexidine. So have them rinse for the first week of the month with the chlorhexidine, and then the next 3 weeks in the month, then they would use some sort of arginine toothpaste or some sort of xylitol products or something to change the biofilm. And then repeat that every month. So 1 week on the chlorhexidine, and then 3 weeks on the xylitol or the arginine or whatever they need to change the biofilm. And that's been shown to be effective as well. Just remember, rinsing with the chlorhexidine is going to negate any effect of fluoride. So if your patient brushes their teeth and then rinses with the chlorhexidine, they just lost all the benefit of the fluoride. So in this case, you'd probably want to rinse first, wait a little bit, and then brush your teeth afterwards. Okay. Chlorhexidine is kind of acidic, so it's not really helping with the pH of the mouth. It's probably lowering it a little bit. And then you all know chlorhexidine, if you use it for more than about 10 days, it'll stain the teeth. And it's kind of hard to get the staining off, so you have to be careful. When we talked about the three amigos in the saliva and how they're super effective when they're paired up with iodine. So some people were thinking about rinsing their mouth with the providone iodine. And it's, very, very effective germicidal agent. It tastes horrible. Some people, especially people with seafood allergies, are going to have a severe allergic reaction for it. You definitely don't want to use it with pregnant patients. And there's really no firm conclusion on how effective it is for preventing caries. So the theory is there, but nobody's really followed up to show that it's very good for preventing caries. There's been some anecdotal reports of use for preventing caries, but nothing more than that. So Colgate and a lot of their other related products have triclosan in them, which is a broad spectrum antimicrobial agent, and there's some studies that have shown that it has reduced levels of plaque as compared to just regular toothpaste. But then there's been incidences of bacterial resistance also. So when it gets used in everything like this, then it's easy for to select for resistant bacteria. So it has kind of some mixed results. Okay, essential oils. Essential oils have been shown to be effective at killing microorganisms, but kind of blows up their cell walls. Listerine has some mouth rinses that have the essential oils in them. They're super acidic, so it may kill the bugs, but then it doesn't. It just makes the environment more helpful to those bugs to grow back also. So again, if you're going to use something like this, you want to make sure and change the environment to something that's more conducive to growing the commensal bacteria. Okay. And then there's all sorts of things out there. There's oil pulling, and it's supposed to do everything to make you healthier, as well as reduce cavities. But we have no evidence that this is actually does what it's supposed to. But it, again, reminds me of my other grandmother who used to say, "You kids need to have some castor oil." Then we talked about the licorice extract, the Chinese licorice, and so that has some very strong activity against strep mutans. It's kind of a nice idea. You just have a lollipop and fight your cavities that way. But again, it's very specific against strep mutans. And there's a bunch of other bacteria that cause decay. So it would probably be most effective for patients who have high counts of strep mutans and nothing else. So very specific use for these ones. Just up the road in Pasadena, they're making the Senadent oral rinse. It's a very nice basic mouth rinse, and it has an antibacterial agent in it as well. And so it's been shown to be pretty effective at changing the environment. Yes.
So these
So it wouldn't be my first choice, the Listerine. So while it kills the bacteria on one hand, it doesn't, it just doesn't do anything to change the environment. So probably wouldn't be my first choice. Whereas the Senadent would be more of my first choice, or a better choice, because it's very basic and it kills the bugs. Any other questions? Still.